Hello, this is Breakout Session 1. Welcome everybody. My name is Mike Payne, and I will be moderating this session. Please submit your questions to the question and answer, and I will learn as we go and keep us on time and whatnot. I'm very pleased to introduce Dr. Susan Hunter, who is an associate professor in the physical therapy department here in London at Western University. And Dr. Hunter is presenting today on her work on understanding falls after lower limb amputation.
Great, thank you very much, Mike. I'm just going to share my screen. Okay.
And we see your screen and we hear you. Thank you.
Lovely. Okay. So I have a particular interest in falls, and particularly in the understanding of the occurrence of falls in people after lower limb amputation. So first off, I want to state that I have no conflicts of interest to report, and that I have 3 objectives. One is to talk about the risk factors that we do understand are associated with falls, describe concern of falling, which is one of the consequences for people who have fallen, and to demonstrate the experiences of people with lower limb amputation who fall and their fall prevention strategies that they actually use. So first off is just looking at what the magnitude of this issue is. And we know that falls in adults, and this is everyone over the age of 18 who has a lower limb amputation, falls are very common. It's in excess of 43% of lower limb amputees will fall at least once each year. Importantly as well, the most common activity that has been reported the person is performing at the time of their fall is walking on a level surface using their prosthesis and just doing their normal everyday activities. So it's not engaging in risky behaviors or in risky situations. Consequences of falls can be dire. They include physical injury, such as fractures, as well as head injury, and fear of falling. And that the increased fear of falling, the psychological consequences of falls or near falls, can lead to self-limited prosthesis use, social withdrawal, and a reduced quality of life. So let's talk about gait for a little bit, since that is the #1 activity people are performing at the time that they fall. And we know that even after people have successfully gone through and graduated from an inpatient or rehabilitation program, being fit with a prosthesis and being able to use the prosthesis, difficulties with gait last long term. And they include problems with how fast people are able to walk. They tend to be more unstable with their walk compared to controls, age-matched controls. And there's also asymmetry deficits in that they don't have a symmetrical gait pattern with their prosthesis. And it's estimated that 41% of people who have lower limb amputations report of having to concentrate on every step they take. So it's important to realize that actually walking with a prosthesis is a very cognitively demanding as well as physically demanding task for individuals. And a recent paper published last year noted that when they asked people with lower limb loss about their concerns with walking, did they again articulated that it was a cognitively demanding task, that they reported increased attention, that they always had to be consciously aware and always planning and if and how they were going to move through their environment, be at home or being outside, and an overwhelming need to be careful to avoid falling during physical tasks. So there is this psychological burden of people engaging in activities that we actually want them to be able to do. And there is this fear that something will happen. And we know that instability with walking increases when people are distracted or when they're walking in complex environments, such as being outside, talking, carrying on a conversation with someone. So gait, that we consider an automatic task for the most part, for people with limb loss, it becomes a non-automatic task in a sense. So when we look at occurrence of falls for people after lower limb amputation, our research group has divided it up into 5 phases. So we have the immediate post-op period that is within the acute care hospital after the amputation. There's a pre-prosthetic phase between discharge from hospital and admission into an inpatient rehabilitation program. There's a time while they're actually in the prosthetic rehabilitation program. There's the period of time once they've graduated and are returning to their community. And then the post-prosthetic phase, so once people cease using their prosthesis. And so we wanted to look at what are the variations in occurrence of falls, risk factors, what can we say about the occurrence of falls across these different time frames. And so for this study, where we had a systematic review that was published in 2017, we searched the available literature and found papers had been published in the area of the post-op acute hospital, the prosthetic rehab phase, as well as the community phase. And falls in older adults is used as a comparator group. Falls in older adults, about 35% of them will fall at least once a year, and that level of occurrence is considered a significant public health concern and crisis, actually. People who have lower limb amputations, they're falling in excess of that. So there should be a greater onus, and at least equal onus, on trying to understand their limitations. So when we look at what we understand from very rich literature on falls in older adults, some of the risk factors for lower extremity amputees are shared amongst these. So lower extremity muscle weakness, increasing age, increasing number of comorbidities, and number of prescription medications are associated with an increased risk for falls. But there are also unique factors that are associated with falls. We have dysvascular etiology that is in relation to alterations in sensation. The person may also, their non-amputated limb may not be healthy. There may be issues related to their diabetes on the other side. There will be also alterations in perception of sensation, so the brain doesn't have information to help process where we are in space or be able to recover from balance perturbations. So that goes in. We know that reduced sense of vibration is associated with an increased risk for falls. People who have a transtibial level amputation are at increased risk of falls in the postoperative period, and people with transfemoral level amputations are at an increased risk for falls in the post-rehabilitation phase of things. There's also some recent research that's come out that shows that even for people with upper extremity amputations, they're at an increased risk for falls as well. So it's not just lower extremity, we are seeing that there are bigger issues. So again, we were able to identify the post-op acute phase, the prosthetic rehab phase, and the new normal, the post-discharge. We decided to do a research study looking at that time between being discharged from hospital and when they're admitted to inpatient rehabilitation. And we chose that time frame. One was an identified aspect of care, and that people may not transfer directly from the acute care hospital into a rehabilitation program. So we did a retrospective chart study looking at 440 consecutive admissions to the inpatient prosthetic rehabilitation program at Parkwood Institute in London. The mean age for people was almost 62 years, and that the mean length of time from the surgery was about 164 days. And on admission into the rehabilitation program, people were asked about falls from the time they went home from the hospital after their amputation to the day of their admission. And the results were very interesting. What we found was that almost 61% of people reported having at least one fall. Number of falls ranged from no all the way up to 20, and almost 55% of people reported having recurrent falls during this time phase. Risk for any fall, it was increased for bilateral transtibial. Oh, actually, sorry. So risk for fall. Bilateral transtibial amputations was actually protective. They had a 41% reduced risk of having a fall during that window in their care. For people who had diabetes, they had an 18% increased risk for falls compared to people who did not have a diabetes diagnosis. And the risk for recurrent falls was highest for people who had unilateral transtibial, with a 59% increased risk compared to people who didn't have a transtibial. And we put this down as that the people who have the transtibial are probably more ambulatory than definitely bilateral or even transfemoral amputations, and that for bilateral transtibial being protective in the any fall category is that they won't be ambulatory. So they're not exposed to opportunities to actually fall. So again, very interesting. So we were able to complete that gap. And what we found was that about 21% of people fall in that post-op period while they're in hospital. Almost 61% fall between discharge home and admission to their rehabilitation. Anywhere from 21 to about 35% fall in rehab. After discharge, again, over 43%, anywhere between 43 and 58% of people fall. So very, very high occurrence of falls. So I talked about not only is there risk for physical injuries, but there's also a risk for concern of falling, where people end up self-limiting activity that they're capable of doing. And one of the most common tools that are used in amputee rehabilitation is what's called the activity-specific balance confidence scale. It takes 16 tasks and asks the person to rate them on a scale of 0 to 100, how confident they are that they will not lose their balance or become unsteady when they perform the tasks. And these are tasks such as walking around the house, sweeping the floor, walking up and down a ramp. And we know that these subjective complaints of lack of confidence leads to a downward spiral because people end up self-limiting their activity. And we know that self-efficacy has an impact on rehabilitation, social activity, and again, community engagement. So it's not just the fall, the physical aspect of the fall, but it is also the psychological consequences of the falls that are concerns. And it's important to take note of what lower extremity amputees are telling us are challenging activities to perform. So this is work from one of my graduate students, Christian Nugent. And we asked community ambulators what were challenging activities. And we broke them into activities, daily living, and environmental factors. And they reported activities such as ascending, descending stairs, bending over, house and yard work, rapid movements or reaching overhead. Environmental factors were unfamiliar environments, uneven or slippery surfaces, no mobility supports, obstructive view of the feet. So again, these are just everyday activities that this group of individuals defines as being challenging, even after successful graduation, a rehabilitation program, and are considered functional community ambulators. So another thing we wanted to look at is that falls education is built into the rehabilitation program at Parkwood Institute. It's not compartmentalized as formal classes, but the information is fitted in through their rehabilitation stay. So we wanted to actually, what do people take away from that information, rather than what do we teach them? Want to know what do our graduates retain, and then how do they understand risk factors, and what do they put in place to try to prevent falls? So this was a study looking at 27 individuals at graduation from their inpatient rehabilitation program, and then we followed them up at 4 months. And at discharge, 89% of the individuals believed that they would fall in the upcoming year. And that of those first, 89% believed that falls could be prevented. 78% believed that they would fall into 12 months after discharge. So they all had a very high expectation that this was just going to be part and parcel of their new life. We did find that only 29% fell between discharge and our 4-month follow-up. And that by the time that 4-month period that they had been home, people re-established their sense of risk. So it went from 78% to 37%. So there is something about the person going home to their regular environment that will influence their ideas of success and what does that risk look like. Importantly, we found that their physical performance in those 4 months after discharge improved considerably. Statistically significant, their gait velocity improved and their time on doing the C.E.T.S was halved. But when we looked at what their confidence was, it didn't change over time. And the figure here is just to show the 16 items within the activity-specific balanced confidence scale. Gray was discharge and the black was the 4-month follow-up. And on each of the items, we really didn't see that much difference between their scores. Interesting, they were more confident, but the scale didn't show it. So this comes back to the initial talk that Dr. Mayo did, that I think we need to look more at the validity of the scales that we are using. The activity-specific balanced confidence scale was developed for community-dwelling older adults and may not be relevant on all items for people with lower extremity amputations. But in terms of looking at knowledge for the people who graduated, we asked participants to rate how likely 13 factors would make an individual with a prosthesis fall. And the 13 factors were all risk factors. So we expected them to be uniformly ranked highly. And the scores range from 0% that it wasn't a risk to 100% being likely. And this provides a summary for what they identified. And that the top 3 factors that they identified was walking on ice and snow, performing risky activities, and not paying attention to one's surroundings. So it's interesting that the most, the highest risk that the group assigned were for things external to themselves, and that balance and coordination was the lowest ranked thing. So there's a lack of seeing themselves and what they physically bring to tasks as being as relevant as their environment. But it's very important to realize that really falls and how competent someone is in being able to perform a task is really a combination of the person's physical abilities, the task that the person is being asked or is performing, as well as the environment that they perform it in. So our group are missing some elements within here. And when we looked at falls strategy, it was interesting that our participants felt that falls prevention relative to their other health conditions was rated at 7.6 on a scale out of 10, 10 being the most important factor. So they rated it very highly as a need to be able to prevent these falls. And individuals reported 85 modifications that were done, and about an average, there were 3. And we had 5 categories that we identified. So we had people who did modifications to the physical home environment, and that was the most common at 80% reported that. And this included installing grab bars, clearing clutter, or rearranging furniture. Use of supportive equipment while mobilizing, so it's just using a cane or mobility aid, was only about 7%. Behavioral change was that increased awareness or alertness to their environment, was about 6%. Moving in a particular manner, again, is being more aware of the environment, was at 6%. And unfortunately, activity and exercise, none of them mentioned that as a strategy that they would be using to prevent falls. And we know that physical activity as well as exercise is very successful in preventing falls in other patient groups, but it wasn't highlighted amongst our group. And just this year, there was the first study that was published that actually looked at the lived experience of falls among people with lower limb amputation. And they actually got their sought to understand how falls impacted them. So it was a focus group of 25 people with lower limb amputations. And their four kind of main findings were that location and ground conditions influence whether a fall occurs. And that can be the ice or slippery circumstances. Fall-related situations also often involve the prosthesis. So that reiterates earlier research that said that falls occurred most often when people were walking with their prosthesis. Not all activities have the same risk for falls, so there is that gradient that people need to anticipate. And not only falls, but near falls can also be problematic. And so this reaffirms that the concern of falling is an important area that merits greater attention within rehabilitation, and it can't be just the physical aspect of making someone stronger. So in terms of fall prevention, there's limited research actually that's specific to lower extremity amputees. There's limited research on interventions as well to address concern of falling within this group. And that given the existing, it's also important to understand that risk factors for falls vary across the care settings, and prevention strategies probably should be targeted and will vary depending on the setting. Occurrence is high across all age groups. Health professionals' input into fall prevention education and strategies is very important. And that 80% report of home modifications reflects a focus on making changes within the home. So we need to make sure that we are very expansive in what we provide to people in terms of education and how people can prevent falls. And it's not just their environment, they also need to think about the factors that they bring to it, and particularly the need to continue to be active to maintain their strengths. And the other important thing is that falls prevention is very important to this group of individuals. So in summary, falls are common for people with lower limb amputations. Use of prostheses are physically and cognitively challenging activity. Physical and psychological features are related to falls. Falls have adverse effects on participation, social activity, prosthesis use, and quality of life. And research in the area of self-efficacy, walking, and falls prevention is still needed to advance providing optimal care. And there should be time for a couple of questions.
Yeah, thank you, Susan. There is a question here from James Tung, who says, I find the bilateral fall rate fascinating. Other than the reduced walking mechanism, do you think there's something else happening to reduce the risk of falls, which I also find fascinating, James?
Yeah, and definitely within that acute or that in-between phase, it probably does has a lot that they are non-ambulatory and are probably more aware of the need to have assistance, even if it's for transfers or activities such as that. Whereas unilateral, there may be the need to actually see what they can do or challenge themselves or try to stay active as much as possible. But it would be interesting to actually ask the people. And we just had numbers. We didn't have their input on what they do and why they do.
I think it certainly does sound paradoxical just to see that number, that an older person, dysvascular, bilateral limb loss would have, more falls than a younger person. Audrey Zucker-Levin, does type of prosthesis have any impact?
There definitely for efficiency and quality of gait, there is work out there that does make a difference, particularly for transtibial and having better knee joints, mechanical, or actually the transfemoral knee joints in the prostheses does seem to improve gait and decrease the cognitive burden for walking. It's not an area that has a lot of research, and it's not something that our group has specifically looked at, but there might be something within that as well, for sure. Lots of research about how to create a better prosthesis, but there's been, I would say, little overlap of groups to look at what are the long-term consequences, or what are the consequences related to falls.
Thank you. Arzu Izragi just popped off my screen. Thank you for the talk. Great topic. It's interesting that APTs only considered external factors. We agree. While their cognition, balance, neuropathy in the sound limb and the other side have major effects, and as well as dual tasking, which is something that Dr. Hunter knows all about, not directly commented on here.
Yeah, yeah. I think it has more to do with what they're hearing and specific actions that maybe we give people as we're training them for going home. So if you hear, you put in grab bars, do this, it's something easy to check off the list versus maybe continue to engage in an exercise program. That's a little bit more daunting than just doing a single thing that might have benefit. Again, I'm also, because we didn't look at what they were taught, we looked at what people took away from the course of being in rehab. And it might be interesting to look at the other side and include that component to see where is the mismatch of information and how to actually enhance what people are taking away. So,
right. Maybe one more question, and then I will cut us off here for lunch. Stephanie Semino, thanks for the interesting talk. And just a question about any sex or gender differences in terms of fall rate or risk of falls.
Nothing has been looked at, though most of the research, as in the population who have at least lower extremity amputations, it is very prominently male. And so no, we don't have anything looking at that. And it might be interesting, again, just looking at physical capacity, it might vary based on whether they're men or women.
Great. Thank you, Susan, Dr. Hunter, for that presentation. We will put a hold on that now. Break for lunch. We start up again 12:30 with our scientific keynote. And in the meantime, please visit exhibitors and sponsors. There's the scavenger hunt with very answerable questions and a chance to win a $100 PC brand e-gift card. So thanks again, and we'll see everybody back then.
Thank you.